Neuroanatomy and Labat's law.
Yes, sir.
Today in
Thank you,
our
sir.
session by MIOT students, we have Dr. Risha to start with on sciatic nerve anatomy and Labat technique.
Yeah.
Over
Thank
to
you, sir.
Dr. Risha. Thank you.
Thank you, sir. Uh, the sacral plexus, it is derived from the lumbosacral trunk of L4, L5, and uh, first, first to fourth sacral anterior rami plexus, which emerges within the pelvis. The sacral nerve, which is a part of lumbosacral plexus, it is the thickest nerve in the body, and the upper part forms about 2 centimeter wide, which pelvis and terminates just above the popliteal fossa by dividing into two parts, tibial and the common peroneal nerve. And it is the largest branch of sacral plexus with a root value of L4, L5, S1, S2, S3. That it has two parts, like the tibial part, which is a ventral division of anterior primary rami L4 to S3, and a common peroneal nerve, the dorsal division with a root value of L4 to S2. The course of sciatic nerve, it runs downwards below the piriformis with slightly lateral between the ischial tuberosity and the greater trochanter. So in pelvis, it is in front of piriformis under the fascia. In gluteal region, it enters via the greater sciatic foramen below the piriformis, and the relation will be superiorly gluteus maximus. Deep and anterior will be body of ischium, capsule of hip joint, tendon of obturator internus and gemelli muscles, and the quadratus femoris, obturator externus, and the adductor magnus upper and the transverse fibers. The medially, there will be gluteal nerves and vessels in terms of gluteal area relation. Coming to thigh area, the sciatic nerve enters the thigh at the lower border of gluteus maximus. It runs downwards up to popliteal fossa. At the upper two-third and lower one-third of thigh, it terminates into two parts. The relations is superiorly crosses the long head. It will be adductor magnus, and the medial side it will be semitendinosus and semimembranosus muscle. The branches will be articular branches to hip joint are given in when coming along the gluteal areas, and muscular branches will be given by the to semitendinosus, semimembranosus, adductor magnus, and biceps femoris long head. In common peroneal nerve, in the thigh area, it gives branches into short head of biceps femoris. The tibial branch further descends vertically down into popliteal fossa, gives muscular branches to the ankle flexors, and sural nerve, like cutaneous innervations on the lateral part, and articular branches to the knee and the ankle joint. Terminal branches of tibial part is medial and the lateral plantar nerves, which supply the sole area of the ankle joints, sole area of the foot. This common peroneal nerve, which has a lateral course along the head and neck of fibula, and the articular branches to the knee joint and to the sural nerve before splitting to the end branches. The terminal branches of common peroneal nerve will be superficial and deep peroneal branches supplying the ankle and foot. And coming to the approach, the Labat's approach, just originated in 1923. It is typically a transgluteal approach. The position for this will be a lateral decubitus position with the operative side up and knee flexed. Landmark for this will be a greater trochanter and a line drawn between the greater trochanter and posterior superior iliac spine. And the second line is drawn from the midpoint of first line, which is perpendicular and drawn chorded for 3 centimeter. And we should mark this area. This is a site of needle insertion. When with the nerve stimulators, we can see a plantar flexion or inversion if we hit on the tibial compartment. We can see a dorsiflexion inversion when we hit on the deep peroneal nerves, the common peroneal nerves. A modified Labat techniques was introduced by Winnie. Here the position is same with the lateral decubitus position. The landmark is a bit different, like a line from the greater trochanter to posterior superior iliac spine, and second line from greater trochanter to sacral hiatus. Here, point of needle insertion is we should draw a line perpendicular to the first line midpoint of this line, we should insert a needle. Usually 3 to 5 centimeter from here, we will hit the nerve. That's all. Further other approaches have been introduced, like parasacral approach, subgluteal approach, and anterior approaches. Among them, popliteal approach is what we commonly use.
All those things are not
That's a
necessary.
fact.
When they ask specifically a particular technique, you can just stop with the description of that particular technique alone. So this is a straightforward question. Have you ever done a sciatic nerve block or seen a sciatic nerve block being done?
Yes, sir. We have performed.
Okay, very good. So when you use a nerve locator to locate the sciatic nerve, will you get the, what is the depth at which you will reach the nerve usually? Risha, your connectivity is okay? There's some problem or issue with the connectivity. Vidya, are you able to hear me?
Correct.
What is the depth usually? How much depth you have to insert the needle? What is the length of the needle? What type of needle you use for eliciting nerve stimulation? Can you describe? Huh? Because what muscles you go through?
Yes.
When you try to do a sciatic nerve block, what are the muscles through which you pierce and go?
Gluteus maximus.
We use two
So
needles, sir.
gluteus maximus is a thick muscle or a very thin muscle?
A band of
Muscle.
thick muscle. A thick muscle.
It's a thick muscle along with a lot of fat covering that. So you may have to go at least 3 to 4 centimeters deep. So if you have a long needle, then only you will be able to reach. Okay, so you have to describe the length of the needle, size of the needle, and then when you initially insert the needle with a nerve locator into the muscle, will you get any contraction of the gluteus muscles?
Yes, sir.
Sir.
So will it cause any discomfort to the patient?
Yes, sir.
Yes,
So
sir.
what is
The
the,
posterior
how do you
cutaneous
overcome
bone.
that problem?
So we have to
I
explain the patient
reversible
clearly
infiltration.
regarding it, and we have to give them sedation, and we need to hold the patient and support the patient in the lateral positions.
So these are all things which you have to include in your description. Okay, and lateral position with the operative side topmost. That is the very important description. You should not just say lateral position. You should say the operative side should be topmost. And you have to do a preparation. Always when they ask for a block, always I used to tell you, you have to remember 4 P's. Position of the patient, preparation of the area, palpation of the anatomical landmarks, and puncture and direction of the needle. Then these 4 P's, if you describe, that will be easy for the examiners to understand that you know the block well, and you will get more marks by describing it like this. Okay, very good. So this is a very straightforward question. Anyway, just for your visual impression, I will share my screen. Let us see how it goes. The screen visible now?
Yes,
Yes,
sir.
Okay. So the question is, describe the anatomy of the sciatic nerve or Labat'S technique of blocking it. Okay. The sciatic nerve is derived from, always write the root value first. Lumbosacral plexus L4 to S5, S3 root. So you can draw a simple line diagram like this, marking the L4, L5, S1, S2, S3. And there is a supplemental small thing you can omit or you can draw to see what it is. somewhat comparable to the brachial plexus. Okay, so you should be able to draw all these lines correctly, and also mention the branches coming off at the formation stage, and how the sciatic nerve is formed in the two components, namely the tibial component and the peroneal or fibular portion. Okay. So all that description is given in the book, so that is not a problem. So after formation, it leaves the pelvis and enters the gluteal region via the greater sciatic foramen. This is a very important landmark. And this picture tells you how the sciatic nerve exists under the piriformis muscle. This is one of the important muscles which cover the nerve at the point of exit from the pelvis through the greater sciatic foramen. So it emerges inferior to the piriformis muscle and descends into an inferolateral direction. Inferolateral direction goes on the posterior side. And as the nerve moves through the gluteal region, it crosses the posterior surface of all these muscles, the superior gemellus, inferior gemellus, and quadriceps femoris. These three muscles. So it lies over all these three muscles. And then, so this picture tells you how this the first one is the gluteus medius muscle, which has been cut to expose the nerve. Second is the gluteus maximus. And then the superior gluteal artery and superior gluteal nerve are very close to this nerve. And the piriformis muscle is there. And the inferior gluteal artery, inferior gluteal nerve. All these are the close relations to sciatic nerve. And here you can see this is the nerve coming out. And these are all the other structures which are in close relationship to that. So it then enters the posterior thigh by passing deep to the long end of biceps femoris. And within the posterior thigh, the nerve gives rise to branches to the hamstring muscles and adductor magnus. And when the sciatic nerve reaches the apex of the popliteal fossa, this is a very important landmark for your knowledge of how to block this nerve at the popliteal fossa. So popliteal fossa is more or less a triangular area. So when it reaches the apex, it terminates by bifurcating into tibial and common peroneal nerves. So this is another picture to show the dorsal and ventral divisions. Instead of saying anterior and posterior, always the spinal nerves are called as dorsal division and ventral rami. Dorsal rami or ventral rami, instead of anterior and posterior will be a better description. So the yellow things are all dorsal rami, the pink ones are the ventral rami, and that is how the whole thing forms. So all the ventral rami go to contribute mainly to the tibial component. And all the dorsal rami go to form the common peroneal or fibular component. This is another picture for you to just remember how to draw these pictures. And these are all the nerves which are emanating from the root level: superior gluteal nerve, inferior gluteal nerve, nerve to piriformis, and all the small nerves like perforating cutaneous nerve, posterior femoral cutaneous nerve, obturator muscle, nerve to obturator muscle. So all these branches are coming from that. And this is the picture to show how it runs up to the foot. So the entire posterior aspect of the leg is supplied only by sciatic nerve. So anything to be done on the posterior aspect, you have to mainly block the sciatic nerve to achieve a good analgesia for all the surgeries that are done on the posterior. And in the Labat'S classical approach, the patient is placed in the lateral position with the operative side up. The leg is flexed at the knee. If the patient is unable to flex the knee, then it can be kept extended also at the hip as far as possible without causing any discomfort to the patient. Then first thing is you draw a line between the greater trochanter to the posterior superior iliac spine. Then draw a second line from the greater trochanter to the patient's sacral hiatus. This is Winnie's modification. But in the original Labat's technique, what he described was you draw a line connecting the greater trochanter to the posterior superior iliac spine, identify the midpoint, Then draw a vertical line for about 5 centimeters, and that will be the point of insertion. That was our original Labat's description. But because sometimes this point may not be the accurate point where the sciatic nerve emerges. Sometimes you have some variations in the anatomy. So Winnie modified it by drawing another line so that you will reach the sciatic nerve even there is a variation. That is the purpose of this modification. So determine the point of initial needle insertion by drawing a perpendicular line from the midpoint of the first line. So you can actually measure the entire length of that first line you are drawing between the greater trochanter to the posterior iliac spine. And if it is say 20 centimeters in a patient, you have to mark it at the midpoint 10 centimeters. If it is 22 centimeters in another little bigger patient, it may be 11 centimeters. So you have to choose the midpoint and then draw the second line from that. So this picture tells you this is the greater trochanter, which will be a diffuse bony landmark, and this is the posterior superior iliac spine, which you will find little lateral to the midline, and you connect these two, and then draw a perpendicular line at 90 degrees from the midpoint. And if you measure 5 centimeters and then insert the needle in this vertical line, that is original Labat's technique. On the contrary, if you draw the second line connecting the greater trochanter to the sacral hiatus, and the point of intersection of this needle, the vertical line, will be more or less in the same line. And the third method is to identify the furrow line or the small depression that will be formed by the gluteus maximus muscle, and that line also will be cutting the second line. This is the line connecting the greater trochanter and the sacral hiatus, and that will also be end up in the same point. So these are the methods of identifying, and you use a 21 gauge 10 centimeter insulated needle for majority of the patients. For obese patients, you may require a 15 centimeter needle also. So the description of what type of needle you have to use is also very important. And this is where you fix the positive electrode. And the negative electrode is always attached to the needle to identify. Then you can, sometimes if you want a continuous block, you can use a 18 gauge 10 centimeter insulated 2C needle for catheter placement. And we insert catheters 5 centimeter beyond the needle tip so that it will stay there without getting slipped out. And when they using the stimulator, initially use the current strength of 1 to 1.5 milliamperes. Insert the needle perpendicular to all planes. This is the point of insertion. And stimulation of the patient's gluteus maximus is often encountered before sciatic nerve is stimulated. And this may be uncomfortable for the patient. So you have to either pass it very fast through that without waiting or delaying there, or you have to use adequate sedation in the form of midazolam and a small dose of fentanyl for the patient to tolerate this. And successful needle placement in the proximity of your sciatic nerve, it may produce a plantar flexion and inversion, which is indicative of stimulating the tibial nerve. But if you get a dorsiflexion, sometimes you may have an inadequate analgesia. So always aim for plantar flexion and inversion, which always block both the tibial component and the common peroneal component. So if you get a dorsiflexion, adjust the needle a little bit more towards the medial side, because the component is on the lateral side. You go a little medial and try to elicit the tibial nerve, and which will result in plantar flexion. So your ultimate goal should be to get a plantar flexion and inversion, which will be more successful than getting a dorsiflexion. Occasionally, the hamstring muscle twitching will be noted, which suggests the needle tip has been placed too medial also, and slight adjustment will succeed in getting the. You can see how the needle is being used to enter the point of insertion. And the local anesthetic, most adults, you use about 20 to 30 ml of 2% xylitol or 0.5% bupivacaine. you have to use the maximum concentration because it's a very thick nerve. The thickest nerve in the body, as big as your thumb, so it has both motor and sensory components. So smaller concentrations may not be able to completely block the entire nerve, so you have to use a higher concentration. So these are the points that we have to remember with regard to sciatic nerve block. Okay?
Yes, sir.
Right. Any doubts or any questions on that? And of
No,
course,
sir.
you can put a small chart where you can show what are the muscular branches, what are the sensory branches to various things. Instead of writing lines, I forgot to include that. You can put a chart where you can just divide them into muscular and sensory branches and then just mention the names alone. That will save a
Yes,
lot of time and at the same time complete the answer. Okay?
Yes.
Right. So shall we go to the next question? Who is going to present the next one? Sobita, Sanjita, who's
I'll
ready?
present the next question, sir.
Please go ahead, ma.
Yes, sir. My question is, what